أنا باسم الشافي أرقيك من كل سقام يؤذيك بيميني أمسح ما تشكو وبعمر الباقي أفديك وأتمتم دمعا ودعاء يرعاك الله ويشفيك وأتمتم دمعا ودعاء يرعاك الله ويشفيك لا بأس.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. إن الحمد لله نحمده ونشكره ونستغفره ونعوذ بالله من شرور أنفسنا ومن سيئات أعمالنا. من يهده الله فلا مضل له ومن يضلل فلا هادي له. نشهد أن لا إله إلا الله وحده لا شريك له ونشهد أن محمدا عبده ورسوله وبعد. Listeners and viewers at home, you are again welcome to another episode of Health Talk in our darling program Ummat Maston TV, and I am your regular anchor, Dr. Lukman Shitu, and I have in the studio with me again Dr. Abdurrahman Tawfiq, a consultant general surgeon from the Department of Surgery, Federal Medical Center, Bida in Niger State. Please, I want Dr. Tawfiq to please say testing to the viewers at home.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa rahmatullahi wa barakatuh. Dr. Tawfiq has been here before where he started a topic with us, and that topic, of course, is a very wide one, and we cannot finish it at a goal. So we started it, and alhamdulillah, we still have him in our studio today to continue with the topic, because we want to at least let our viewers to have total understanding, at least, if not total, at least the understanding that will make us have a way out of the problem. So not for us alone, even for people around us, because they said information is power. The moment you have information, some of these avoidable death we are having among us in West Africa, and particularly in Nigeria, is uncalled for. So we want our doctor to continue with the topic we discussed in the last episode. In the last episode, if you remember, we discussed cancer, a global disease. In that episode, we treated what is cancer, what are the distribution rates across the world, and what are the risk factors, and the screening and early detection. These are some of the questions that we were able to iron out in our last episode, and that we are unable to get to the treatment itself. So today, our doctor will give us the way out of the problem. Now that we know early detection is crucial and the stage is crucial, what of if one is already in the problem? What is the treatment option? Doctor, what are the main treatment options available for cancer patients, as you started in the last episode?
Alhamdulillah Rabbil Alameen. Well, I think we need to understand that for the treatment of cancer disease, there are usually allocated aims. And this has to be because of the staging of cancer itself. So when you want to treat cancer, you define your aim. So usually for early cancers, like in our previous editions, we usually aim for cure. But late cancers and advanced cancer, what our aim usually be is what we regard to as palliation, that is to improve quality of life. Nobody goes after cure. Now, treatment in cancer is multimodal and is multidisciplinary. When we say multimodal, it has a whole lot of modalities that you can use to treat cancer. And when you say multidisciplinary, it means it cuts across several specialties. Because in medicine, either medicine or surgery, there are subspecialty. And when we talk about subspecialty, is narrowing down to a particular aspect of the body as the sole area of your own specialization.
Okay.
For example, in medicine, you can have somebody that is specializing in treatment of cardiovascular diseases.
Okay.
You can have somebody that's specializing in treatment of respiratory diseases.
Okay.
You can have somebody specializing in treatment of renal diseases, and like that. And in surgery, somebody can narrow down to taking care of the heart alone. That we refer to them as ophthalmologists. And somebody can also narrow himself down to an endocrine surgeon that takes care of all those things that has to do with. And we have plastic and reconstructive surgery that take care of the skin diseases, surgery pertaining to the skin.
Okay.
And every other reconstructive procedures.
Okay.
And orthopedics and trauma. So there are several specialties. So when you say multidisciplinary, it means that cancer treatment can sometimes cut across so many specialties coming together to take care of that disease. And when you say multi-modality, there are specific treatment modality. Each treatment modality stand on its own. And sometimes you may have to combine 1, 2, or 3 to treat a particular cancer. Now, treatment aim are usually, I said there are 2. It's either curative or palliation. Now,
curative or palliation. Okay.
So then the target of treatment can be for 2 reasons too. Number 1 can be for what we refer to as locoregional control of cancerous disease.
Locoregional?
Yes.
Okay.
That is the locality where the cancer is happening and the region, the adjacent area.
Okay.
You can define you can target the treatment to do that.
Okay.
Then the other arm of it is what we refer to as systemic control.
Okay.
Systemic control now means that in addition to the fact that you are taking care of where the cancer has happened and the surroundings, you are also pursuing the cancer where it has gone to lodge itself in distant places. So within the bloodstreams. That's what you say is systemic.
Okay.
Now, I now say, what are the various modalities that you can use in treating cancer? So we have surgery. Surgery is one of the modalities. We have what we refer to as radiotherapy. It's another modality. Then we have these 2, surgery and radiotherapy. Their aim or their target is usually locoregional control.
Okay.
Now, all these other ones I'm going to mention, they are usually systemic control.
Okay.
So one can adopt chemotherapy.
Okay.
Then there is what we call biological therapies.
Okay.
And there is what we refer to as hormonal therapies.
Okay.
Then we have immunotherapies too.
Immunotherapy.
Yes, and we can do combination of any of these.
Any of those. Okay.
Now let me go one after the other. When you say surgery, it's actually oftentimes is the primary treatment of most cancer.
Okay.
Surgery means going there to remove the cancerous lesion. So if it is localized to that area of the body, you want go as much as possible to remove the cancer cell and part of the normal cells with it. So if one does that, sometimes that may be the only thing that cancer will require if it is early and it's localized there.
That's not affected other parts.
Yes. So, and sometimes if it's locoregional now, maybe they're not adjacent to that cancer, there are some other areas that are having that you can see. You also use your surgery to remove all those things. That's why surgery is the first modality. Now, the second modality is radiotherapy. Radiotherapy is when we make use of some special light. We call them ionizing radiations. So they are specially defined to kill cancer cells.
Okay.
So these lights have been designed in such a way that they can be focused on a cancer cell and killed it. It has quantity, it has amount, so people are trained to carry out these things, because if it is not well done, it can cause damage to
other cells.
So when we make use of this radiotherapy too, it is also targeted to achieve what we call local regional control
of the cancer.
So now these two can be combined. That, like, for example, if we use surgery to take cancer cell out of a particular place, then when we now look at it under microscope, or we'll give it to another set of physicians that they call them pathologists. So when they look at it, they now tell you, say, what you caught, you have removed, but there are still some leftover there. So that's leftover, your eye cannot see them. So now those leftover, and this thing is only localized to that area, it has not gone to any other area, but those leftover, if you don't take care of them,
they will still regrow.
They can regrow. So you have two options. The first option is either you go back and recut further to include those areas. But if persistently, when you go there, you cut, you are still having leftover there, the best thing you can do that time is to bring in radiotherapy. So those remnant one, if they focus those radiotherapy on them, it will kill them.
Okay, that's
so that is
the requirement of the radiotherapy.
Most cancer.
Okay.
Now, when you now talk about, and also, unlike surgery, surgery is primary to most tumor. Even in an advanced stage, you still want to, the surgery has a role to play. But for radiotherapy, it becomes useful for cancer that are sensitive to radiotherapy. Because there are some cancer that this radiotherapy, they will resist it. You cannot
kill them with the cells will not just die.
Yes. So we categorize a cancer that we treat with radiotherapy as either radiosensitive or radioresistant. So if they are radiosensitive, it means that once you use radiotherapy on them, they will respond.
Okay.
So, but if there are some that, if you don't know their characteristics and you are using radiotherapy on them, they are radioresistant, they will not yield, and the effect of radiotherapy will tell on the normal tissues around there and also on the patient. So that's why you need this knowledge to tackle cancer. Now, the other modality is chemotherapy.
Okay.
Chemotherapy means, because literally when you say chemotherapy, it means using some chemicals for treatment, which could also entail some of the other chemicals we are using to treat diseases that are not cancer. Because when you say chemicals, the antibiotics we are taking, they are chemicals. The anti-malaria we are taking, they are chemicals. But solely this name, when you say you are using chemotherapy, it's referring to drugs that are regarded as cytotoxics.
Cytotoxics.
That is, drugs that kill cells.
Okay.
Antibiotics doesn't kill cells. Anti-malaria doesn't kill cells.
What does it do then?
Antibiotics go after a microorganism and kill that microorganism. In fact, it is either little or no effect on normal cells. Anti-malaria does the same thing. Pursue the malaria parasite, kill the malaria parasite with little or no harm on the normal cells. But for this chemotherapy that is solely used for cancer drugs, they are regarded as cytotoxic. Cyto means cells. Toxic means that it's killing. Something to be toxic to something. So now these things are toxic against cells, whether they are normal cells or they are abnormal cells. So they are designed to kill cancer cells, and in the process they also affect normal cells. That's why the modality of administering chemotherapy is such that we understand this principle, that this chemotherapy, as they are killing cancer cells, they also have effect on normal cells. So because of that, oftentimes when chemotherapy is going to be administered, they are administered in sequence. So that when you give it the first time, both normal and the cancer cells will be affected. But within a short while, when we say something is normal, it means that the normal cell still retain its quality of growth control, unlike cancer cell that has lost that mechanism. So within that space of time that is given for the normal cell to recover, that's when another dose will be given to the cancer cell. So this is just the principle of how chemotherapy is being used.
Doctor, before you leave that place, sorry for cutting in. What is the efficacy of this chemotherapy and of a thing? Is it the last resort, or it's still there that when what is done, there is high chance of survival? Because sometimes when we hear it as a layman at home, that when we hear it is the chemotherapy or the first one you mentioned, radiotherapy, that is going to be employed, will almost lose hope. What is the efficacy of those measures?
Well, the efficacy of all these modalities, they are first and foremost, they are dependent on the stage at which the tumor is presenting, the cancer is presenting. And the second efficacy of it is dependent on how sensitive the cancer is to these modalities. So now the efficacy of it is that they are actually effective. Both radiotherapy and chemotherapy, they are effective provided the cancer is sensitive to them. And of course, two of them, they have side effects. And there are measures to guide against those side effects, to make sure that those side effects are significantly reduced. Another thing is that patient composition are different. Patient tolerates this drug more than the other. So oftentimes, majority of the patients, they will complain that they are not finding it easy. But even with that, there are measures put in place to limit and significantly reduce the side effect that will come with this chemotherapy. But they are highly effective, and they take care of the cancer cell very, very well with good response. But we should bear in mind it's dependent on the stage of the cancer is presenting. For early stage, we are still aiming for cure. For late stage, we are not running after cure. Now, if this chemotherapy now, what we should understand is that it kills both cancer cells and normal cells. So there are modalities guiding how it is administered. Because it affects normal cells also. So before it is administered, we usually run a number of tests to be very sure that the patient is fit to take the medication. Because if we don't ascertain patient fitness for this modality, it worsens their condition. In fact, sometimes we may need to reduce the expected dose that's supposed to be given to them when we have evaluated them and feel they are not fit to take a full dose. Then we reduce it to a tolerable dose. So that assessment is what we regarded as assessing the performance status of the patient before administering any
other drugs or
this modality. You must assess. Sometimes, like I said, surgery is primary treatment of most cancers. But sometimes if we assess the patient and patient cannot even go under anesthesia, talkless of doing surgery, then we will delay that surgery until the patient is fit to be able to tolerate that surgical procedure.
Doctor, so thank you so much.
The other modalities, biological, hormonal therapy, immunotherapy, they also have a way by which they work.
Thank you, Doctor. We will have to take another, when we start talking of the specific type of cancer, I think that some of those areas, we will take them as they are peculiar to individuals. So we may not be able to exhaust some of those specific treatment measures today. But I want us to go to one other area, and that is the prognosis and survival rate. What factors influence a patient's prognosis and after a cancer diagnosis?
Yes, the prognosis of cancer is important because prognosis simply means what's the outcome of this cancer disease after intervention.
Okay.
So, and this is tied to the presentation of the cancer disease. For cancers that are presented early, that we can achieve cure, they have a good prognosis.
Okay.
So then cancer that present late, they have a poor prognosis.
Okay.
Then there are some cancer, once you have them, you are happy because we oftentimes there are some head and neck cancers that we talk about. When we say head and neck cancers, that is cancer that occur in the region of the neck and the head. So because they are likely to present early, and oftentimes some of them are sensitive to radiotherapy, and even so when you pick these kind of cancers and they are responding to treatment, they have better outcome. And even prostate cancer as it is has a better outcome compared to other form of cancer disease. So the hallmark of it is that the prognosis of cancer depends on the presentation and the stage of the cancer. For early stages, they have better outcome.
Okay.
Late stages, they have poor outcome.
Please, I want us to go into the survival rate. What's the survival rate of the cancer, especially in this part of the world, the West Africa and particularly Nigeria?
Survival rate varies, and it depends on the type of cancer you are dealing with.
Okay.
But we usually talk about 5 year, 10 year survival rate for so which may range depending on the type of cancer.
Okay.
So it depends. For sometimes you grade them by saying if patient comes stages 1 and stage 2, what is the likelihood? They usually have a higher survival rate. Stages early
presentation.
they have very high, in the range of 90-95%. That is when you have 100 people and 90 or 95 of them will survive, will live, will escape it. Usually higher with early stages. But in late stages, when you talk about their survival rate, is usually lower, maybe in the range of 20, sometimes 25%, and may even be lower. So that is, the emphasis is just that we should make sure that we screen ourselves so that we can present early, and so that this thing can be detected early and we can be focusing on cure.
Thank you so much, Doctor. Let us, before we round up for today's episode, I want us to go to some area and one other area, that is the follow-up care. What does follow-up care involve? And for someone who has undergone those cancer treatment?
Yes. Follow-up care is usually for patients to follow up patients to have further treatment.
Okay.
Or to follow up patients to detect possible recurrence.
Okay.
Or complications.
Okay.
So when you say follow-up care, the first time you are meeting a patient presenting with symptoms of cancer is the first contact.
Okay.
And having evaluated the patient, having talked with the patient, having counseled the patient, talk to the patient about the disease and the likelihood of what could happen to the patient.
Okay.
Then you follow up on what you ask the patient to do.
Okay.
Investigations, even if the patient is to come, which is a family member, to do a conference meeting, you follow up on all this to ensure that you reach a conclusive end. So when that is done, that is to evaluate the patient further and determine the type of treatment the patient will have. But the main follow-up, when you talk, follow-up means when, is you have diagnosed the patient, you have finalized. You have now decided on what you want to do for the patient. It's either you want to observe the patient for some time. While you are observing, you are monitoring the patient and you are taking some measures to determine whether to intervene or not. Or you have operated on the patient. You have given the patient any of this treatment modality. And let's say you are either aiming for cure or is not palliation. So if it is for cure, having over the patient the necessary treatment you will advise the patient to go for additional treatment if it is not available in your own center. For example, you have offered the patient a surgery and you think the patient will need radiotherapy, which is not available here. Part of the follow-up is that you refer the patient to a center where radiotherapy can be delivered. Having done the radiotherapy, patient comes back to you for follow-up. If patient will still benefit from additional treatment of chemotherapy, you place the patient on it or any other form of treatment modality. Now, having done this, you will now be following up the patient, and depending on the type of cancer, there may be need for you to do some specific investigations just to look for example, if you have a dual organ in the patient, where you are, maybe the cancer you are dealing with now is a dual organ, for example, breast. And one breast has a cancer disease and you have taken care of that, you have completed the treatment of that cancer disease. Now, part of the follow-up is that you will be inviting the patient, giving the patient appointment sequentially. When the patient comes, you check the patient for recurrence in this area where you have treated, and you check for the other one for possible of a new growth. It's just like a screening. You are screening that. Because nothing is in that breast. But part of the follow-up you are doing is that you are checking this one has been cured and I don't want any other thing to come up there. So you are checking, is there any recurrence? So if there is recurrence, what's the extent of that recurrence? Is it just local to that area or it has even gotten to other part of the body? Now, this other one part of the follow-up, will now be doing some investigation which included the lack of mammography and even ultrasound to see where need be. You may need to do what we call breast MRI. So one will do this thing to make sure, see, this other breast doesn't have anything, and if it has anything, I want to pick it early. Because as we have emphasized, if you pick it early, the chances of cure is higher.
Thank you so much, doctor. I want the doctor to give us the take home, and the area I want the doctor to please look at is what is the cost effective? In this area, in this part of the world, some of this, the cost of treating cancer. What is it? Is it affordable to the poor? And comparing treatment and early detection, what advice do you have for our audience and the listeners at home?
Well, I think let me say globally, there is nowhere that healthcare is cheap. Anywhere in the world, healthcare spending is very, very expensive. What makes it to look as if we are suffering in this part of the world is because of the method of our healthcare delivery. Healthcare delivery in most places is being taken over by the government and they subsidize it for the populace. But in Nigeria and in most African countries is an individual spending. So, and that's what makes it to be very, very difficult. So the treatment of cancer is actually is an expensive thing. It's not an easy thing. So, and that is my advice to people is that prevention, like they used to say, is better than cure. If we can subject ourselves to screening as at when due and offer ourselves for treatment as early as possible, we will spend, but it's not going to be as spending when it is peak late. We will spend more, in fact 10 times more than what we will have spent if it is peak early, and the chances of not surviving is still there.
That is exactly there.
So what I would advise is that the treatment of cancer, like we have highlighted out, is actually effective and people can get cured if they present early. But one of the problems we have is our dual or multiple belief. Some still believe, as we are talking, that this is just science. They still want to try their own local method, and by the time they will be coming to the hospital, it's already late. So I would advise viewers at home that cancer is a curable disease if it is peak early. I am saying it authoritatively. But majority of us in Nigeria, in most developing nations, will present late because we have attempted different other modality at home. It is when it's not yielding that will now come to hospital. And we make mistake a lot because some of us, we compare the disease of somebody to another person, whereas it may be a different thing. For example, somebody having a breast problem and it was treated using your local medication and it got cured. So another person will now have another breast problem. Maybe the breast problem that you treated that got cured was never a cancer. And you will now be saying, this kind of thing I treated it with for somebody and it got cured. So this is another area where we have problem. So that when you have problem, let's make effort to consult with the specialist and let's be diagnosed early so that we can get cured.
Thank you so much, Doctor. We really appreciate our Doctor for this beautiful presentation, and we pray unto Allah to continue to enrich him in knowledge and preserve him for Islam. We want our viewers to please pick, and we must have picked one or two things from this discussion. It's not only informative, it's entertaining, and it's something that we need to at least look into critically, especially the area of early the screening and early detection. You know, this it's a popular saying that prevention, they say, is better than cure. So if this is presented early and we go for tests and what have you, that will save us even the cost. And the cost is even less. It will save us our life most times. So we pray unto Allah to enrich us and give us the opportunity of living for him. It's on the note that we want to wrap it up. And as we used to say, please subscribe to our channel, and you can place advert on our program. We, inshallah, until we come your way next time, we say assalamu alaikum wa rahmatullahi wa barakatuh.